Welcome to Coeur de Roy, the heart of clinical care. I'm your host, Dr. Roy Ziegelstein. For those who don't know me, I'm a cardiologist and professor of medicine at Johns Hopkins University School of Medicine, as well as the editor-in-chief of Dynamed, which is part of EBSCO Clinical Decisions. But enough about me. I'm delighted to kick off with a fantastic episode today, including a great interview with Dr. Brian Garibaldi, professor of medicine at Northwestern Feinberg School of Medicine, among other accolades. Brian and I will discuss his specialty, bedside medicine, and also talk about technology and trust, which I know are at the forefront of our listeners' minds. We'll also introduce a number of segments that you'll see as a recurring theme, digging deeper into compelling research, technological advancements, and potentially a few hot takes. Before we get into it, I'd also be remiss if I didn't thank Brian, who, in addition to an accomplished physician and educator, is also an exceptional musician. The music you heard at the beginning of this episode is actually his own composition, and I'm really honored that it's part of this podcast. And with that, let's get into it. For my first segment, I'd like to introduce what we're calling Recapping the Research, where we'll discuss the latest peer-reviewed studies or major reports from reputable associations and the clinical implications, or maybe just research that interests me. In this case, I'm going to talk about 3 studies that interest me, one on coffee and tea intake and dementia, one on the American Heart Association statistics on heart disease and stroke, and one on smartwatches and hypertension. So first, a study in the Journal of the American Medical Association on coffee and tea intake and dementia risk, that really caught my attention, caught my eye, mostly, frankly, because I'm a coffee drinker. I drink coffee every day, and so when I read this study on the possibility that caffeinated coffee intake may lower dementia risk, I thought it was really interesting, and I'm just going to talk for a minute about it. They looked at over 130,000 people who were in their 40s and 50s at the beginning of the study, and they followed them for 40 years. And what they found is that those that drank 2 to 3 cups of caffeinated coffee or 1 to 2 cups of tea every day, they seemed to have a lower risk of dementia than individuals that drank much less or didn't drink at all. And that caught my attention. I'm now drinking my coffee with more gusto and feeling better about it. The study is an observational study. It's important that observational studies really don't actually look at causation. That's important to note. But I thought it was interesting nevertheless and wanted to highlight it here as something that interested me. The second study was the American Heart Association's 2026 Heart Disease and Stroke Statistics that was published in Circulation recently. This is a really good study, very important statistics, really what you might call a tour de force, in that it was very well researched and clearly described. It talks a lot about the things that put people at risk for heart disease, and it really goes through what you might expect: smoking, physical activity, diet, weight, sleep, cholesterol, blood pressure, and blood sugar in what they call life's essential 8. But I think that there was something missing in the document, frankly, and that would be on the importance of psychosocial health, especially social isolation, loneliness, and depression. Those are actually really important, and in fact, the American Heart Association also thinks it's important, and they recognize it in other parts of their publications. But I think they missed the opportunity here to add that to life's essential 8, maybe call it life's critical 9, or even separate out the psychological and the social and call it life's critical 10. The third study is a study very recently in the Journal of the American Medical Association on the impact of Smartwatch on hypertension detection. I think this is a study that is really kind of interesting because it touches on the potential benefits as well as the potential harm. That's important, as well as the potential harm from screening for hypertension, or I would say screening in general. When screening is done for health conditions, the potential benefits are kind of obvious to people. That is, if you detect something that's important and potentially treatable, that sounds good. However, the potential for harm may not always be as obvious. And in this case, it may actually create needless anxiety or may prompt unnecessary interactions with an already overburdened healthcare system. So I think that this is a nice study in terms of thinking about potential risks, potential harms, again, in this case, from Smartwatch detection of high blood pressure. But I think it really prompts or should prompt a discussion about screening in general. So that's what's been on my mind, those 3 studies. I think they're interesting, and we'll have a link to the studies in the show notes if you want to take a look at these studies yourself and maybe share your own opinions. On to another segment, this one dubbed Tech Talk, where we'll discuss innovations in technology, whether it's AI, wearables, or something not yet known. We'll discuss the promises, perils, and potential implications of these technologies. I wanted to talk a little bit about AI in the clinical space. You know, there's so many different potentials for AI to make our work more efficient as clinicians. You know, for example, there's AI ambient scribes, there's AI chart digestion, there's AI first draft messaging to patients, and of course, there's AI clinical decision support. I actually believe that all these things have great promise. Of course, we recognize that, sometimes things that have promise don't deliver. For example, it's possible that generative AI might make some things less efficient and maybe even add to workload. For example, if AI is not trustworthy and it doesn't do its job well, actually the clinician may have to spend more time reviewing, verifying, and even fixing things that the AI does that are, bottom line, mistakes. And, that part was actually featured recently in The Pit, for those of you that are fans like I am. In The Pit, Dr. Santos needed to catch up on her clinical documentation using AI, and it turns out AI made some mistakes that she didn't catch, and she didn't edit, she didn't review, and so forth, and she got in a little bit of trouble for that. So I recognize that the promise may not be delivered, but I'm very optimistic that AI is going to actually make things more efficient and give clinicians more time to really get to know their patients as people so they can apply evidence-based clinical decision support to the care of each individual patient they see. Well, those are the things that are interesting me in technology, and I'm interested to hear what you think. So if you have a different opinion, or maybe you have the same opinion and you want to share it, please tell me about it on social, LinkedIn, or any way that you think you want to highlight what we just talked about. For today's final segment, I'd like to turn up the heat at least a little with what we call hot takes. These are my opinions. They're not affiliated with my employers. They might be a little controversial from time to time. Some months will directly confront bad science or misconceptions that are making headlines. And as always, we'll lean into what the data says. But today, I'd love to start with just sort of something that might be like a little teaser for you. Imagine if a particular airline experienced a series of accidents with fatalities. It would take no time at all before no one would travel on that airline. And that's because the media would pick it up right away, and the public would learn quickly that a particular airline was a safety risk. And that's actually good in my view. But what if the same happened if clinicians using a particular clinical decision support tool made decisions that jeopardized patients' health and, in fact, led to patient harm? There wouldn't be the same kind of public outcry because it might be hidden from the media, and that's too bad, in my view. My opinion is that it shouldn't take a long time for the public to learn if, in fact, patients were harmed by a clinical decision support tool that wasn't trustworthy. My question for you is, what do you think? I'm eager to hear your view. It's a pleasure for me to introduce Dr. Brian Garibaldi, a really esteemed colleague and good friend. Brian is the Charles Horace Mayo Professor of Medicine at Northwestern Feinberg School of Medicine, and he's the director of the Northwestern Center for Bedside Medicine. He's a professor of pulmonary and critical care medicine, but really the bottom line is he is the most respected and admired master of clinical medicine in the world, from my perspective. We're going to be talking about three things today. First, of course, the bedside examination. Second, the role of technology in the bedside examination. And then third, the issue of trust and trustworthiness, which is so important at the bedside with patients. Brian, welcome here. Can you just tell us a little bit more about you and how you became so interested in bedside medicine?
Well, Roy, thank you so much for the invitation to be here today and for that really kind introduction. I think my interest in bedside medicine really began in medical school. And, it's not a coincidence that you invited me to do this podcast, because my rotation in the CCU at Bayview when you were the attending as a third-year medical student was one of those seminal moments that helped me understand what's possible when you go to the bedside with intent and with curiosity, and you really listen to the patient's story, and you look at the signs and symptoms that are there to help you understand what's happening. And so for me, that journey really began as a medical student. And it also, as I joined faculty, as I was a chief resident, beginning to see patients through the lens of what is it that I can understand about them as individuals and how that helps us make clinical decisions, it really becomes apparent how powerful time with patients is. And as you begin to do more of that, I also began to realize how little of it we actually spend with our patients. And I think I was struck by, in my own career, I had this incredible opportunity through Johns Hopkins to work in Malaysia for a year, where I was the head of a pathophysiology curriculum at a medical school in Kuala Lumpur, Malaysia. But one of my jobs was to help set up the clinical rotations in the hospital. And we were assigned to this ward that had 30 beds, and they were in 5 bays of 6. And it was just an incredible clinical experience. The first bay was always patients with hemorrhagic dengue. We were in the middle of the largest dengue outbreak in Malaysia's history at that time. The second pod was dedicated to patients with tuberculosis, because that was the pod that was closest to the window. And then the other 3 pods were, whatever happened to be in the hospital that day. And it became very apparent that the Malaysian clinicians were much better than I was at that time at going to the bedside, hearing a patient's story, listening to really what they were saying, but then also using the physical exam and occasionally technology, but mostly the physical exam, to then guide the next step in their management workup. At first pass, I thought, well, maybe they're better than me because they have to be, because they don't have the same technology that I had accessible in Baltimore during my training. But that wasn't true. They had the same 5 Tesla magnet MRI. They had the same CT scanner that we had in Baltimore, but they chose to access it differently. And in fact, if you wanted to get that CT scan, you had to go to the radiologist, present the clinical case, present your physical exam, present your interpretation of the chest x-ray. And 9 times out of 10, you already had the information that you needed to make a diagnosis and come up with a management plan. So the other thing that was driving their excellence was not just the way they chose to access tests, it was also the way that they assessed clinical skills. In Malaysia and many other countries throughout the world, they sit for something called the MRCP PACES exam, where you have to examine real patients with real findings in front of attendings who themselves adjudicate what the findings are and determine what the passing level will be for that day. And the simple existence of that assessment means that Malaysian clinicians think about how to get better at the physical exam every time they see a patient. It's part of what they do. Every Friday was PACES rounds, and that was my first indication of how I needed to be much more intentional in my own training to get better at observation skills and physical exam skills. And when I came back to Baltimore after that year in Malaysia, I went to Sanjay Desai, who was the program director of the Ulster program, and said, hey, we need to do something about this. I need to get better at my own ability to teach these skills, but we also need to think about how can we design an environment that encourages excellence in these skills beyond just the traditional excellence that Hopkins has always had.
That's great. Thanks, Brian. Brian, this may sound like too simple or naive of a question, but what do you consider to be the components of the bedside exam?
Well, I think it starts the moment you encounter your patient. And maybe we should even back up further. The bedside, traditionally, it makes you think of the hospital, but the bedside is anywhere where a patient is, whether there's a healthcare provider. So the bedside traditionally is the hospital, the clinic. During COVID, we all grappled with how to make telemedicine a part of what we do in terms of our clinical skills. But now with the ability to remotely monitor patients and gather data on people throughout the whole course of their lives, the bedside is a markedly wider and broader place than it used to be. But I think for me, it starts with observation. The moment you walk out into the waiting room or the moment you walk into the hospital room, beginning to understand what is the context of this individual, who's in the room with them, what things do they have with them in the room, and then that leads very quickly into building rapport. And that's one of the things that I think we sometimes forget to spend a lot of time teaching. We try to model it when we can, but building rapport with a complete stranger who you're then going to jump in and start asking very, very intimate personal questions about things they might not talk about with anyone else in their lives, including their loved ones. That's a skill, and that's an important part of the bedside observation. Then obviously listening. One of the most important things is to very quickly get through that rapport building and then listen, stop talking. Let the patient tell you what it is that's on their mind. And most often they will get to the questions you would have asked if you just let them talk about what's on their mind. And then obviously I spend a lot of time thinking about the role of the physical exam in helping us gather additional information and refining hypotheses. And I want to be very careful to say when I say physical exam, particularly over the last 10 years, that includes technology. That includes hand-carried ultrasound, includes digital stethoscopes. Now it includes AI decision support tools and even ways of using AI to gather information, particularly on image recognition or even motion recognition now with different AI video recognition software tools.
And in fact, I was about to segue to technology so that you did a natural segue of your own. First, I want to congratulate you also on your recent New England Journal paper on the bedside exam. I thought it was really, one could say, a tour de force, and it's about time that the New England Journal of Medicine published a great paper on the bedside exam. So I was doing a little bit of math this morning, which is always dangerous, okay? But bear with me for a second. In your New England Journal paper, you cite your own findings that have been confirmed by others that medical trainees spend as little as 13% of their time in direct contact with patients. That, by the way, might surprise a lot of people that are not in medicine, right? So here's the math. If even all of that 13% was spent examining patients, and we know that it isn't, because there's lots of other stuff that you do at the bedside. In fact, you just named a few things. But even if all 13% was spent examining patients, we know that medical trainees are not allowed to spend more than 80 hours a week in training, about 50 weeks a year, if you'll allow me to just average. So given that, they're only spending at most 500 hours a year examining patients, even if all of the time at the bedside was actually spent examining the patients. Now, I know that the 10,000 hour rule has been debated, Brian, but let's just say for a minute that we agree that you need about 10,000 hours of deliberate practice to master a skill. That would mean at 500 hours a year that medical trainees would need 20 years at the bedside to master the exam. So my question for you is not whether you think that medicine training should be 20 years, because I'm assuming you don't think so. But the question is, can technology, which has made so many processes more efficient, can it make learning the bedside exam more efficient?
Well, I think there are ways in which technology can help you understand what's possible at the bedside. So, for example, for years I would give talks about the importance of observation skills and show a picture of a herpes zoster rash, which is a reminder for me that sometimes bedside observation is the diagnosis. There's no sensitivity or specificity for a zoster rash because that is the diagnosis itself. But now you have AI tools that can reach a sensitivity and specificity well into the high 90s in terms of recognizing a zoster rash. So I think it's possible that there will be some ways in which technology allows us to tap into what used to be something that would take you 10 years to recognize or 1,000 exemplars before you're really comfortable with all the variations of a zoster rash, and will alert you to the possibility that what you're seeing in front of you may in fact be zoster, and open your mind to that possibility. And so I think you can tap into that wealth of knowledge and experience through different AI tools to hopefully help you get to an answer faster. But I think it is really important to remember that particularly with clinical reasoning, a lot of the large language models are dependent upon the inputs that we provide. And so right now in my own practice, I would be very skeptical of a large language model that used data from the documented physical exam and the medical record to help you come to a decision. Because we know if we go to the hospital right now, there are many patients with equal and bilateral pulses who are missing limbs, right? Or patients who have, you name the copy and paste or templated exam that exists in the chart that we know is not accurate. And in fact, one of the ways we're looking to see if our trainees are doing a physical exam, we're piloting this as a measure, is did they actually change the template of the physical exam? That may in fact be a marker that you at least thought about the exam. Maybe you actually did it and you're changing it because you recognize there was something that was different from your template. So I think technology is going to be helpful, but I think we need to be very mindful of the inputs. We need to be mindful of bias. I mentioned I think dermatology is a really great example of this. We know that both AI systems as well as human clinicians are less able to make the diagnosis of rare skin diseases, but also common skin diseases in dark-skinned patients, because the training data sets and the textbooks that we've all looked at traditionally have been mostly white patients. That's changing. There are lots of people who are doing outstanding work in this area to change that. But we do need to be mindful about the possibility of introducing that bias into our own practice when we start using these tools.
In that great paper that I'm talking about in the New England Journal, you also talk about the fact that in yesteryear, we'll say Osler's time, or even before that, there were gold standards that people used to train. They used autopsies, pathological examinations, as you point out, or even rounding with the great Sir William Osler. I think technology might actually provide a gold standard today. When I learned medicine, I listened to the heart, I listened to the lungs, and then I said, okay, I guess I'm hearing this murmur. I guess I'm hearing these findings in the lung. But now we have ultrasound, for example, at the point of care. And we have other things that you mentioned, for example, point of care clinical decision support, that maybe it doesn't replace Osler, but it certainly can provide a gold standard from my perspective in terms of medical knowledge. So my question now, as we sort of make the full segue to technology and the bedside exam, clearly people are used to thinking of technology as standing in the way of the relationship between doctors and patients. In fact, you even talk in your paper about Laennec's invention of the stethoscope more than 200 years ago and how people view that with some degree of skepticism and concern. And there's no doubt that we teach students, residents, fellows to be fully present and engaged with patients. So the question is, how does the introduction of technology at the bedside, how does it affect that ability? And how do we ensure that their attention is going to the people right in front of them?
So I'm glad you mentioned, I've been thinking a lot about the historical context of technology at the bedside. So you mentioned the stethoscope, which was probably the first diagnostic tool that was routinely used at the bedside. And then very quickly after that, in that next 80 years, you had the invention of the ophthalmoscope, the thermometer, the sphygmomanometer for blood pressure. And each one of those things provided a new objective data point, quote unquote objective data point. But what was interesting is that they still were acquired by the primary physician who was acquiring that data and then using it in real time at the bedside to help with diagnosis and management reasoning. And then we had the invention of the chest x-ray, which was the first piece of technology that happened remote from a patient, was interpreted oftentimes not by the primary person who ordered it. And that led to sort of this valuing of this remote objective clinical data, and particularly vision over touch and what you hear. But I think technology now, as it exists, provides us an opportunity to get back to the patient. So one of the most wonderful things about POCUS is, number one, if you want to get good at it, you have to go in the room where the patient is. Although I think there is a new company that has a robot ultrasound machine, which I'm not sure I am a big fan of. You have to get comfortable going into the room with the patient. You have to develop rapport. You have to learn how to appropriately drape the patient so you can examine the part of the body that you want to ultrasound, because you can't ultrasound through clothing. And just by doing that, simply by wanting to get good at ultrasound, you have to get good at those other skills, and that builds connection. But it also builds incredible connection when you can show a patient, hey, I'm worried that your lung is surrounded by fluid. Here's the pocket of fluid. Look, here's your normal lung. We don't see this pocket of fluid, and here's the pocket of fluid. This is why we're concerned about you. This is why we're considering doing these other procedures. This is why we might consider using a really long needle to drain some fluid out of your chest. And that's been shown in multiple studies to build connection with patients. They begin to be engaged more with their disease process. They also recognize, I think there's a particular level of expertise that goes into using these tools, which I think builds trust, right? When you're showing someone, here's exactly what I'm looking at, this is why I'm interpreting the way that I'm interpreting it, and you're doing it in a way that maybe they haven't seen before, that aids in the building of rapport and the building of trust, just as doing an expert physical exam also builds trust. It's very, very oftentimes clinicians will describe examining a patient and the patient saying to them, that's the first time anyone's ever touched my belly. I've been having belly pain for 6 months, and you're the first person who touched my belly. And simply doing that transmits care, but it also transmits a degree of expertise. Something's different about this provider who is engaging in the physical exam this way or using this bit of technology that's really interesting and cool I haven't seen before. And I think that builds connection, that builds trust, that builds patient engagement. And so for me, I love ultrasound in particular because everyone wants to get good at it. Everyone wants to learn it. And we can use it to get people into the room. In fact, I have an ultrasound session this afternoon, but I promise you I'm not going to use the ultrasound first. We're going to do a lot of other things. And by the time we get to the ultrasound, most of the trainees in the room and myself, hopefully, will have a pretty good sense of what the ultrasound is going to show. And the ultrasound then helps us calibrate those traditional skills and helps us build that connection beyond its diagnostic properties.
You once again did a beautiful segue to the next topic, which is on trust and trustworthiness. So really, thank you for doing that. Because the point you just made, I think, is so critical. I have said to people before that actually I think when I use technology at the bedside, for example, POCUS, which is point of care ultrasound, or when I use other technology at the bedside, I think, and apparently you do as well, think that it builds trust and it builds confidence. Have you ever had the sense, though, with a patient of anything other than that, the opposite? Have you ever felt that a patient was wondering, why is this guy not using a stethoscope, or why is he using technology at the bedside to look up evidence-based medicine? Shouldn't he know everything?
Well, I think the experience I've had in that regard is, oftentimes as an ICU physician, I might be the fourth or fifth, many providers since the person first came into the hospital to then meet them and talk with them. And oftentimes patients will say, well, I already talked to 5 different people. Can't you just read the chart? And what I've found in those situations is that I instinctively move quicker to the physical exam, because once I do that, number one, you engage the power of touch, which is, we're evolutionarily hardwired. Touch is important, both for conveying care. We know that it affects the parasympathetic system. We know that touch can have a placebo effect, but it also demonstrates very quickly that I'm doing something different than what they may have experienced before. And I think the same can be true of technology. But I'm very careful. I would never go into a room and just immediately put a ultrasound probe on a patient, right? I carry a hand-carried ultrasound with me in all clinical encounters, and I use it very frequently in ICU patients, but not for everybody. It doesn't answer every question that you have. But I'm very careful that, it's about trying to get to a shared understanding of what the next steps are, helping patients navigate the uncertainty that despite all the testing we have, there's always uncertainty at the bedside. And so tech is a part of that, but I think it would be a mistake to jump straight to the tech, because I think you could run into that problem of, why didn't you talk to me? Why didn't you examine me first? So I'm very careful to, POCUS as an adjunct to the traditional skills that we've been talking about, but it doesn't replace them. There are things that the ultrasound can't hear or can't feel, just as there are things that I can't feel or see or hear that the ultrasound can pick up. They're complementary. The one doesn't replace the other. So I'm very careful to use ultrasound in a hypothesis-driven way. And so I have not personally run into a situation where I jump straight to ultrasound and someone's like, whoa, slow down, talk to me first. Because I think it's not clear that ultrasound is going to be relevant to every case that you see.
Yeah, this is great, Brian. And I think that anyone who didn't know you before this podcast who's listening can understand why I think you're the master of bedside medicine. This is my final question, okay? Or maybe it's the penultimate question. So in order to expect patients to trust technology at the bedside, we as clinicians need to trust it. Now, when I buy an appliance at home, like an electrical appliance, I might be interested in price or efficiency or how long it's going to last or making sure it doesn't catch fire or something like that. So I might go to, any one of a number of different sources of information on the appliance, comparing one brand to another. How do clinicians make the decisions about which technology at the bedside is trustworthy?
So I think that's a really important question, particularly as we start getting into the use of artificial intelligence enhanced clinical reasoning tools. I would say for things like ultrasound and digital stethoscopes, it's still a fairly small market. There are only a few digital stethoscopes that are out there. And so in my own practice, I've just tried to use as many of them as I can. And some are good for certain things. Others are really great for teaching, but maybe not as great for diagnosis. None of the currently available digital stethoscopes that I'm aware of are really good at lung sounds. And they all the companies will tell you that they're actively working on making them better for us to hear lung sounds the way we would hear through an analog stethoscope. But some of them have these new AI algorithms that incorporate a 3-lead EKG, for example, so you can get very accurate determinations of is someone in sinus rhythm, atrial fibrillation, or an undetermined rhythm. Some newer algorithms, there's some data showing that maybe they can actually screen for a reduced ejection fraction. So I think part of it is looking at the data that's available for specific devices, but then also getting comfortable trying out these devices. And for myself, it was borrowing a stethoscope from someone who had a new device that I hadn't seen before. And then I reached out to the manufacturer and said, hey, can I trial one of these? And most of the companies will help you to do that. Ultrasound's a slightly bigger market. There are several companies that have hand-carried devices. There are several companies that have cart-based devices that are maybe at a lower price point than some of the larger machines we might use in the ICU. And I think there it's really a personal decision. There are certain advantages to some of the hand-carried ultrasound devices because of convenience and having multiple probes combined into one, but you sacrifice some of the fidelity of some of the higher cost machines. So I think it depends on your personal circumstance, your clinical context, and your preference at some point. I think we're still trying to figure out how we're going to use some of the emerging AI tools in clinical decision support. But I do think it's really important, particularly for folks who are in a position to educate others. Our students are using this technology in their daily life, right? They're using AI to do lots of things that perhaps we're not. And so I think it's incumbent upon us as educators in particular to be starting to use these devices to understand how they might help us in our own clinical care, but how they might also help us to teach. And so I'm not sure if there's a tried and true way yet of vetting these devices, but I do think we need to be really careful. I remember when I was a pulmonary fellow, our pulmonary fellow class was trained in doing ultrasound guided procedures, particularly thoracenteses. But the only person who was trained on faculty to do it was the person who trained us. And so if he wasn't in the hospital and you wanted to do an ultrasound-guided thoracentesis, I would have an attending say, well, I'm not credentialed to do this, so you can't do it. I'm like, well, I'm not sticking a needle in this person's back without ultrasound because I know that that's not as safe as using the ultrasound. So I think we need to be careful that we don't fall too far behind where our learners are. But we also need to partner with our learners and learn from them. How are you using this particular technology in your daily life? How did you use it in undergraduate education? How are you using it in medical school? And how are you adapting that to the clinical realm? Because I think seeing it through their eyes might actually open our eyes to some of the possibilities that maybe we wouldn't have thought of because we're not using these tools as widely as they are.
Thanks, Brian. And again, thank you so much for participating in the podcast. If listeners sense and admiration that I have for you, it's genuine, sincere. Any last comments or anything we didn't touch on that you wanted to mention?
Well, Ryan, I'm so honored that you invited me to be here today, and I think I mentioned this earlier. You're one of my clinical role models, and one of the reasons that I'm in the position where I am today to run a Center for Bedside Medicine. So I just wanted to start out by saying thank you for that. Thank you for inspiring not just me, but thousands of learners across the country. I hope this podcast continues to do that for a whole another generation of learners, because I think you understand the juxtaposition between getting to know patients as individuals and acquiring and using the data that you can get from the clinical encounter to help them navigate their healthcare journey. So I'm incredibly excited to be a part of this. Hope the podcast continues to grow. And again, thank you for inviting me to be a part of it.
Thanks, Brian. I want to thank you again for joining me today and listening to the podcast. And a special thanks to my guest, Brian. Please stay tuned for more episodes, which will be released the first week of every month. Like and subscribe to be notified of new episodes, and please connect with me on LinkedIn. I'd love to hear your feedback. Until next time, stay true to the core.